Και δεν το λέω έτσι τύπης. Αυτό το συνέδριο πρέπει να παρακολουθείτε από όλους τους καρδιολόγους, σύγχρονους καρδιολόγους, ανεξαρτήτως εξειδίκευσης κτλ. Έτσι, οι εξελίξεις είναι ραγδαίες, πρέπει να μπορούν να αναγνωρίζουν, να διαγνώσουν πιο έγκαιρα μυοκαρδιοπάθηση. Η μυοκαρδιοπάθηση δεν είναι ένα ξεχασμένο κεφάλαιο στην καρδιολογία, ίσα-ίσα, είναι ακριβώς ανάποδο. Περνάμε λοιπόν για του λόγου του αληθές στις επόμενες μυοκαρδιοπάθειες, τις μυτοχονδριακές μυοκαρδιοπάθειες, οι οποίες είναι μια ετερογενής ομάδα διαταραχών που προκαλούνται από τη δυσλειτουργία της μυτοχονδριακής παραγωγής ενέργειας λόγω γενετικών μεταλλάξεων κτλ. Που επηρεάζουν το μυτοχονδριακό ή το πυρηνικό DNA. Γι' αυτό θα μας μιλήσει ο κύριος Savvatis, consultant από το Barts Heart Center του Λονδίνου. Σας ακούμε, κύριε Savvatis.
Ευχαριστώ πολύ. Καταρχάς, να ευχαριστήσω τον καθηγητή κύριο Ευθυμιάδη και τον κύριο Γκώση για την τιμητική πρόσκληση στο εξαιρετικό αυτό συνέδριο. Κατά δεύτερον, νομίζω θα είναι προς συμφέρον όλων μας αν μιλήσω στα αγγλικά, γιατί...
Το ζητάει και κάποιος κύριος από
τέλεια. Είναι πάρα πολύ ευχάριστο τότε αυτό και παρόλο που βέβαια ο Θωμάς μου επισήμανε ότι περισσότεροι όροι που θα χρησιμοποιήσουμε είναι ελληνική μέσα στην ομιλία. So we're staying in the area of ultra-rare diseases, and we're going to talk about mitochondrial diseases. I have no conflicts of interest. As the president has mentioned, mitochondrial diseases are sort of a very heterogeneous pattern of conditions. They are systemic conditions. They can affect most systems in our body. Typical findings are retinitis pigmentosa. They can affect the central nervous system, but all the skeletal muscles as the cardiac muscle. And you can see we've got the two main areas of inheritance. We've got the matrilineal inheritance, because the mitochondria that come from the mother really down to the offsprings. But we also have the nuclear DNA, which are mostly autosomal recessive type of conditions, and they control the way that the mitochondrial DNA is maintained. And you can see here they are rare conditions. We think it's about 1 in 8,000 for the mitochondrial mutations. They are probably more common in the adults, whereas the nuclear DNA types are most commonly seen in children, and they are a bit more rare. Now, when we're talking about mitochondria, we're talking about, these are the normal mitochondria on the left, and then we have what we call heteroplasmy. So some of the mitochondria are normal, some of them carry the mutation, and on extreme case, we've got what we call a homoplasmy, where all the mitochondria inherited are all abnormal. Now you can imagine that every tissue has a bit of a tissue specificity depending on the load of the mitochondria. And this is what, depending on how much is in the heart, and we think that the mechanism that they cause cardiomyopathy is mostly by creating very big, giant mitochondria, which are very dysplastic and dysfunctional, and they can interfere with the function of the sarcomere. As you can imagine, because these are the energy factors of our body, they cause a lot of issues in the oxidation, the glycolysis, the energy production, and that leads to a abnormal fetal gene expression program and changes. Again, the other interesting thing with the mitochondria is that we can see how they generally change in the mitochondria and the cardiac involved in mitochondria. But the progression may depend over years. As we know, there are progressive conditions, but we can have very acute conditions between minutes, from 1 minute to the other, especially in patients who have mitochondrial crisis. They present with lactic acidosis, and we can see Takotsubo or myocarditis presentations in people with cardiogenic shocks, and also progressive changes over the years. But the most common patterns that we see are structural patterns and electrical patterns. On the structural front, we mainly see the hypertrophy, and here the 3243 mutation is the one that more commonly associates with that. You can see dilated phenotypes, you can see also restrictive phenotypes. And in terms of the electrical involvement, here the single large-scale deletions are the most common ones, that they really present with conduction disease. But we can have pre-excitation with Wolff-Parkinson-White syndrome and supraventricular and ventricular arrhythmias. I'm going to show you a case here of a 35-year-old chap who presents with a new diagnosis of elevation to the ECG. He was referred to me with a diagnosis of HCM made previously. So he has some red flags: bilateral sensorineural deafness. He's got episodes of rhabdomyolysis while hiking at high altitude, but also proteinuria. Shortly after I've seen him, he presented with stroke-like symptoms and seizures. As his ECG, probably mostly short SPR, some septal Q waves, especially in the lateral leads. And he's got this sort of concentric LVH on the MRI. As you can see, the most interesting bit is probably the abnormal or unusual late enhancement in the middle picture in areas where hypertrophied, but also in areas which are not really as hypertrophic, and you can see that also in the two-chamber view. And this chap ended up having a diagnosis of a 3243 MELAS mutation. What do we know about this MELAS mutation? There's significant involvement. They can have cardiovascular risk factors. They can have hypertension on a very large proportion. They present with dyslipidemia. They may have diabetes, but they can also have electrical disease. They can have first-degree AV block and conduction disease, but also hypertrophy mainly. And we see in about 1/3 of the cases cardiac involvement here. The LVHs tend to be mostly mild, but we'll see some examples later on as well. Now, from the moment these patients actually present with hypertrophy, then the progression can be very rapid, and they can progress to heart failure and hospitalization for heart failure quite rapidly over a few years. And this is an older study that has shown that. There is a correlation between what we find in the urine load and the blood load and the cardiac involvement. And we can actually improve our seeing what's happening in the heart by measuring this load of the mutation in the urine and the blood. And that's the second chap who is 30 years old. Now, he's got a single large-scale mitochondrial deletion, and these patients present quite early on. They got what we call the Cairns-Say syndrome. And he had a conduction disease, he had an early pacemaker, and also some other typical red flags, the sensorineural deafness, nephrocalcinosis, and epilepsy. You can see here his ECG over the years, that's sort of atypical left bundle to start with, and then he's completely paced in 2021. Progressive systolic dysfunction over the years, requiring that he got upgraded to a CRTP device for progressive dysfunction and high pacing percentage over the years. And we know this as conduction disease is a central hallmark for these patients, especially patients that present with a significant neuromuscular phenotype. Not all of them have a significant neuromuscular phenotype, but the ones that present with that, they can have early on disease and need a pacemaker even before the 18 years of age. Now, the guidelines are relatively diffuse in terms of what we need to do with these patients and when we need to pace them. And generally, the recommendation is that we need to pace them when they present with high-degree AV block. But we know things like hypertrophy, diabetes, as well as hypertrophy and systolic dysfunction and complexes may be significant for the prognosis of those patients. So that's why we continue to do actually this multi-center study, and we published the data in 2022. That's over 600 patients from multiple centers in Europe. And as you can see, about 1/3 of the patients had cardiac involvement. Half of the adverse events were heart failure events as well as arrhythmic events. And we identified as significant risk factors here. We looked at the genotypes, and we can see that the 3243 mutation as well as the single large-scale deletions, which are the most common genetic changes in the mitochondrial conditions, are the ones that are associated with worse prognosis. And you can see the lines differentiate what defines the heart failure outcomes. So patients with 3243 mutation, which is the most common one, and to end up presenting with heart failure around the 35 to 40 years of age. And you can see on the right side where the lines differentiate, whereas the conduction disease and significant pacing indications are almost exclusively associated with the single large-scale deletions. Simple things that we can do in our outpatient clinic to differentiate which patients may be high risk are Holters and ECGs and echocardiograms. And if you have the genotype and you can know that whether they got conduction disease, hypertrophy, or impaired systolic function, you can create a risk score and an easy way to risk stratify these patients and identify which patients may need pacing and which patients may need early treatment or more intense treatment. Sudden death events they have been mentioned in the literature before, but they seem to be quite rare and mostly related to conduction disease or really nerve ventricular arrhythmias as far as we could see on this study. Now, I've mentioned there are some extreme phenotypes, and usually these are the patients that will come to us via the hypertrophic cardiomyopathy clinic or even the dilated cardiomyopathy clinic. And you can see this is a patient with very significant abnormal ECG, very much looking like hypertrophic cardiomyopathy. You can see the atypical and significant hypertrophy, but also the ring-like pattern of late enhancement of the cardiac MRI, which is again very unusual for simple hypertrophic cardiomyopathy, sarcomeric. This is a young chap with an autosomal recessive mitochondrial disease, biventricular hypertrophy, very small cavities, very significant HFpEF presentations. And this is an interesting mutation because this one actually has only cardiac involvement. It's a homoplasmic mutation, the 4300. And again, this is now included in most of the modern panels for HCM and potentially DCM. You can see it causes this asymmetric septal hypertrophy, but also the epicardial late enhancement, significant scarring with progressive systolic dysfunction over the years. Treatment, not much at the moment, but there is gene therapy coming and some various other treatments. So it's mainly supportive, really. So I'm just going to conclude here that cardiac involvement in mitochondria is common. It's about 1/3 of the patients. They can be heart failure and conduction disease, and with a 3243 mutation being the most common one for heart failure, and the large-scale deletions one causing conduction disease. There is a risk score now that available where we can use to stratify in these very specialized outpatient clinics for mitochondrial disease. And the final risk of sudden death is low, so generally ICDs are not really recommended apart from all these extreme phenotypes that I've shown to you. And I will let you with this slide for the red flags. Just always think about systemic involvement and non-cardiac involvement in patients who may end up in our clinic with either DCM or HCM phenotypes or even conduction disease early on. Yeah, thank you very much.
Oh, thank you. Thank you very much, Dr. Savvatis, for this great presentation. But I don't know if there is any question from the audience. Well, we've seen...
No, that's okay.
We've seen this kind of hypertrophies. Then what is the most important differences between the mitochondrial disease and the hypertrophic cardiomyopathy? And when should we suspect the presence of mitochondrial disease in a cardiac patient? Is there any red flags? Or?
Well, that's the clue of the discussion, really, isn't it? Here, the $1,000,000 question. So when you got extra cardiac involvement, most of the patients will have systemic involvement. They will have potentially rhabdomyolysis. They will have muscular involvement. They will have ptosis in the eyes. They may have short PR intervals on the ECG, something that we can potentially see. Biventricular involvement, sometimes right ventricular hypertrophy, specific things on the ECG, and they may have this very unusual patchy late enhancement of the cardiac MRI. So these are things that potentially can pick up. We've looked into, people have looked into in the past in patients that are gene negative. They've been genotyped for HCM. They're gene negative. We do find some mitochondrial mutations there. The 3243 and the 4300 are the most common ones. In about 1 in 10,000 sort of genotype HCM patients, but again, it will depend. It's a biased population because we're looking very much in patients. But yeah, the red flags are pretty much those. Quite often, the patient will come to us from neurology, but there may be the other way around as well.
I'm sorry, Dr. Gossius. It helps the people.
Is there the audience?
There are some people.
So, thank you very much for such an excellent talk. So, one clinical thing we always noticed when we saw these patients is that they had disproportionate shortness of breath sometimes when they exercised compared to what we were expecting on the echocardiogram, so the degree of diastolic function or dysfunction. How consistent is that as a finding? Because of the lactic acidosis, we are always...
Yeah, that's an excellent question. Usually these patients have exactly disproportionate shortness of breath and symptoms. So that the chapter I showed you to start with here, the cardiopulmonary exercise test, and his peak VO2 was 43% of predicted, which by no means has to do with his heart. I mean, clearly they have skeletal muscle myopathy. They've got very impaired energy metabolism. So they are people who will have other issues apart from the heart. So rarely is the heart condition that is their issue.
So a low anaerobic threshold.
Very low aerobic threshold, very high metabolic equivalence on the cardiopulmonary exercise test. So you'll see respiratory equivalence of 1.5, 1.6, so very high.
Yeah, well, sorry to take advantage of your presence here. Fascinating data. I was intrigued by two different points. You mentioned you had written some supplements with a question mark, whether these are helpful. So I wanted you to elaborate on this. And the other, I'm sure there are many cardiomyopathy clinics in the UK, but you mentioned the need of a special clinic. Do you get referrals, with these disorders from other cardiomyopathy centers?
So To answer the first question, I mean, the coenzyme Q10 and riboflavin are things that's been used, but most patients are on that. I don't think there's any clinical data that actually does anything. A lot of patients are going to swear on those, this has changed my life, but actually if you take them away or give them placebo, it probably doesn't quite make a big difference. So coenzyme Q10 is probably the one that makes sense also in an energetic point of view, and they are quite usually, it's not prescribed by the cardiologist, it's mostly prescribed by the neurologist. Now the second question, so we work very closely with the neuromuscular and our neurologists. So London has one of the biggest populations along with Newcastle, so we see about 800 patients with mitochondrial disease. They mainly end up getting referred to the neurology center, and then we are doing the cardiac screening. So that's how normally it works. So again, it's a matter of multidisciplinary care and multidisciplinary.
So these patients are accumulating 2 centers in the UK?
Yeah.
And what about, I'm not sure if you already mentioned, but about the treatment, about the treatment. They use drugs that affect the production of energy, like SGLT2 or inhibitors or GLP-1 activators. What about it?
Yeah, these are all currently in investigation, but there's very good, I mean, no data at the moment around those. Mostly we use some antibodies that can change, reduce the fatty oxide metabolism and the reactive oxygen species within the skeletal muscles. The other big problem is that it's probably happening in other systemic conditions as well, that somebody is running a trial on neurology but never looks in the heart. So I think this is a very common example in most of those systemic conditions. So we don't quite know what's happening in the heart, but there's a lot of work being done at the moment. Thank you very much.
Ευχαριστούμε πολύ. Και παρότι έχουμε φτάσει στο τέλος του τραπεζιού από άποψη χρόνου, θα